Such an esteemed group with us today for the very first Gupta-Klinsky India Institute hybrid event. And I can see that people are not quite ready to join in person still, the vast majority of our audience still being online. But it really, I think, points out the importance of technology in improving life and moving us forward. How would we have survived the pandemic without this? And so today's topic, I think, is really important: empowering health for all, exploring digital innovations for health equity. And I would like to invite Shri Sharma, Assistant Professor, Department of Biomedical Engineering, to say a few words for us.
Thank you, Melody, for this warm introduction. So yeah, just a brief on digital health. So it can have multiple applications and can be understood differently by different people. So for example, telemedicine, healthcare applications, point of care testing services, healthcare data management, AI, machine learning, etc. All of these are components of digital health. It's a technology that can prove to be invaluable to all constituents of the healthcare services value chain, including providers, patients, manufacturers, research, data managers, and so forth. However, given the immense potential that technology has in playing a critical role in providing quality care and reaching to the last mile, does that mean we are close to resolving the issue of inequities in health, a persistent global health concern? The answer, unfortunately, is no. We have miles to tread. There are challenges to digital literacy, data security, technology infrastructure, concerns regarding usability of the product by the end user, and so forth. One can also argue that the overall burden of diseases is rising globally, and given the situation, what role can digital health solutions play in minimizing the divide in access to quality care? We're going to talk a lot about that today. So indeed, these are all very valid questions that require collaborative efforts, investigations informed by multidisciplinary collaborations, dialogue in both scientific and non-scientific communities, cross-cutting research and development, and implementation of evidence-based interventions to create impact. The healthcare sector, I believe, is on the cusp of a digital health revolution. At Johns Hopkins University, we've been relentless in contributing to these efforts through our several projects and innovation hubs, including the Technology Innovation Center, TIC, the Center for Bioengineering Innovation Design right here on campus, CBIT, Center for Digital Health and AI, the Malone Center for Engineering and Healthcare, just amongst a few. On this journey, we have also had the privilege to work with some incredible partners along the way, such as the Indian Institute of Technology, Bombay. With this, I'm going to turn it over to Melody, and then we can get started with our discussion.
Thank you so much. As the new executive director of the Gupta-Klinsky India Institute, one of the big pieces that I see a role that we're playing is really looking for those cross-cutting projects that solve the big health problems through collaboration, interdisciplinary collaboration. So loved hearing your comments around that. And to just jump right in, I'm going to go ahead and introduce our panel. Our representative from the India Institute of Technology, Bombay, Dr. Ramakrishnan is running a little late and will be joining us shortly. Next to him, we have Ritu Agarwal, who is the William Polk Carey Distinguished Professor at the Johns Hopkins Carey Business School. Camille Parikh, who is the Center for Nanomedicine, Wilmer I Institute Center for Bioengineering, Innovation, and Design in the Biomedical Engineering Department. Of course, Shri Sharma, who we have all heard from, the Associate Professor, Department of Biomedical Engineering, Vice Dean for Graduate Education, Whiting School of Engineering. And our moderator for today, Brian Hasselfeld, Senior Medical Director, Digital Health and Innovation, Office of Johns Hopkins Physician, Associate Director, Johns Hopkins in Health, Assistant Professor, General Internal Medicine and Pediatrics, Johns Hopkins School of Medicine. And we will also briefly have with us online Rama Chalapa, Bloomberg Distinguished Professor, Electrical and Computer Engineering and Biomedical Engineering, Chief Scientist, Johns Hopkins Institute for Assured Autonomy. And with that, Brian, I will turn it over to you to begin this interesting conversation.
Thanks, Melody, and I think Sri gave us a very good, broad and deep background around what digital health can mean. A lot of topics inside of that term, and so in that context, this first question might be the most challenging, which is to pick one thing, one disruptive technology that you've seen in your various disciplines that you think is invaluable in providing benefit to communities across the globe. So I know a broad topic with a broad introductory question, and for this one, we'll start by going down the line. And so,
That's great. So my biases are neurological disorders. I study disorders of the nervous system. So what I'm super excited about is sort of what we call closed loop neuromodulation. So the idea is we're re-engineering the brain. We're going to put implants in the brain. For example, let's take epilepsy, where people have seizures at random moments in the day or in the year. Can this chronic implant sense the activity in the brain, see when it's going into a risky zone that's about to trigger a seizure, and actually treat or prevent the seizure from happening through, say, stimulation? So we call that neuromodulation. You're modulating the patterns of the brain. This could be completely, you implant it. It's minimally invasive. I know that sounds a bit strange, but it's actually quite safe. And people can walk around and you can prevent seizures from ever happening. So I'm super excited about that.
And already speaking about the various aspects, many people will think about pure software when talking about digital health, already talking about the real biomechanical interface opportunities that actually go well beyond software. Phenomenal.
Yeah. First, I just want to say congratulations to Rama for being inducted in National Academy of Engineering. It's really incredible. So I feel very grateful to be with so many distinguished people here. I guess to me, if I think about eating a sort of software eating different industries, to me it's now sort of software eating itself, where you don't need to necessarily have now $1 million sort of engineers that are necessarily coding, developing the software that's going to eat and go into different industries, but now there's an underlying sort of AI or software architecture beneath that. And to me, that's what's going to enable access to these innovations and probably allow more of these industries to be disrupted. So to me, it's that sort of underlying engine for creating these innovations in the first place.
An innovation engine for innovation.
So I'm going to have to pick artificial intelligence and wearables as my choice for the following reason, that I think one missing piece in this whole digital health transformation is the fact that we're not able to observe with a lot of granularity the activities of daily living and get real-time data from patients as they go about their lives. And combining wearables with artificial intelligence allows us to develop, what I think of as personalization and digital therapeutics. So if you're going to give somebody an app with some interventions, make sure that it speaks to that individual. So I'm really excited about those possibilities. And the fact that AI now gives us the ability to analyze these large quantities of data in real time.
Rama, we're going to come to you in a second. The next question, Ritu, is going to be focused on the pragmatic implementation of some of that and some of the barriers. But as I say to my patients, we talk about activities of daily living. What better way to talk about that than actually observing you where you daily live, which is not in the clinic. Rama, same question to you around what's most exciting.
Well, I've been involved in computer vision and related fields in AI for almost 40 years. So obviously I'm going to agree with what Ritu and Kunal said. I think the data-driven AI that's become very active over the last 10 years is a disruptive technology. Because before, when medicine when AI was together, that was in the early 70s, so-called MyCin. It's a rule-based system with 450 rules. So AI and medicine go at least 5 decades, but it was really not successfully deployed. Now what we see is data is taking control. But in medicine, without domain knowledge, data really cannot do much. So how you bring the domain back and domain and data together is what's going to make it effective. Now, one of the issues that I face, because we are so much dependent on data, domain shift is something that's going to be a big problem that we have to address. What works for patients in Hopkins may not be so effective for patients in General Hospital in Chennai. Population is different, demography is different, and the kinds of expectations are different. Just to give you a very quick example, South Indian folks, quite a few men have diabetes. Usually, and when they are 40, it looks like most of them get it, at least the Brahmin community, because of the kind of food, the starch, heavily starch food, and also not doing as much physical work as they were doing before, because everybody is on the desk these days. So a diabetes doctor in Chennai would say 2 hours after eating dinner, blood sugar 200 is fine. But the same doctor here would say, no, it should be less than 140. So even simple things like that, how do you adapt when you do a data-based one? Because domain, knowledge is very important. So I think bringing domain back into the deep learning paradigm is something that needs to get done for digital health to be meaningful.
Big data sets, remote monitoring, wearables, AI driving its own innovation, and the biomechanical interface and neuromodulation already a wide variety of topics. We're going to come back, as I said, though, first starting with Ritu around the point of implementation. So going from these ideas that we all just laid out, that you all articulated what's exciting, but then getting all the way to implementation, taking that distance between technology creation and then in healthcare, invention is not the end of the pipe if it doesn't actually touch providers, patients, or otherwise disrupt the delivery system. It isn't making its intended difference. Speaking both for the Indian context and the United States context, which obviously, as Rama just pointed out, will have some key critical differences. What are the potential barriers to pragmatic implementation and an idea or two around addressing them?
So, that's a question that's going to require more than 2 minutes to answer, but let me try and give you, a few talking points. So I just want to observe that digital and health are two industries that have a very different cadence, a very different approach to design, delivery and implementation. And here we have the perfect storm of these two industries coming together. On the one hand, you have a focus on agility, versioning, let's get this stuff out fast. On the other hand, you have a conservative system, and rightly so, and no room for error at all, right? So there have been many, many roadblocks on the way to implementation. But if I were to think about implementation barriers broadly, I would just characterize them as, sort of individual and institutional, if you will. So at the individual level, you've got trust, you've got privacy, confidentiality, digital literacy, the list goes on. And institutionally, and especially so in the Indian context, I've seen hospitals struggle with getting electronic medical records put in place because they don't have the resources, they don't have the technical competence and or the desire of the physicians to use them. So there's just a whole host of barriers. But I think the good news is, there's a field of science, implementation science, that's trying to unpack all of this. I hope we can make some progress.
So for each of these questions, we'll probably see if we want one additional respondent, because we've got a lot of ground to cover. But Sri, Kunal, Rama, anyone want to jump into that topic?
First, so it says individuals versus institutional. At the institutional level, I think you were alluding to this. There's huge issues when trying to generalize a solution. Missing data is obviously a critical piece, and I know people like Ram are working on that. But the variability, different hospitals, different clinicians, nurses capture information differently. And yet if you're trying to build a solution that's working and processing that data, that's a real challenge. Individuals, I think the biggest challenges are early stage development of any technology, digital health or else, which is just knowing who your customer are, doing the customer discovery. We're very naive innovators, right? You can have a great idea, but you don't know what the regulatory pathways. You don't know how you're gonna sell it, pricing. These are early stage sort of mistakes that are made, and they're barriers, and that's why ideas don't necessarily hit the shelves.
And governments are still trying to figure out how to regulate it and how to reimburse for it, so everyone's figuring it out at the same time.
Yeah.
As somebody who is both in SOM and School of Engineering, the biggest challenge I face is having a free-flowing data that we need for machine learning, right? If you can't bring health data to Whiting at all, so you have to have other things which are perfectly appropriate to protect the privacy of data, the HIPAA and all of that. So I have to now put my students in the medical space. And I'll tell you, this is very, it's not, it's kind of funny, not funny. School of Medicine at Hopkins is all window-based system. And now all AI software runs on Ubuntu and Unix and Linux. Just getting the AI software, the best one that's out there to run on Windows system. It may look like a plumbing work, but I tell you, that's a hurdle for us. Kunal and Shri can comment. So these are some of the challenges I'm seeing day to day. So getting, I think Chris Chute is really working very hard to have a large corpus of data available so that we can, we can let loose our machine learning algorithm. So that's one point. The second one is something like PMAP is what we are now looking into and improving it with various machine learning algorithms. So if that can be made a little bit available more, I think we can make a lot of progress. So some of these things are what I call not, highly intellectually challenging, but I see it every day. So I put a lot of 4 of my students in the medical space. We set up the workstations, but this Windows Unix thing is something I don't know what to do. Anyway, I thought I'll just make that point. So we need to be able to scale ourselves up to what the AI environment needs. So that's a big challenge. If it is challenge here, it's challenge in other underdeveloped countries.
So I've always found it, to your point, Rama, I always find it amazing, at least in the United States, you just have to sign on the back of your license that if something, God forbid, happens, you donate your organs.
Right.
You just sign, that's it. Why can't we do something when anytime you register at a hospital, let it be all properly de-identified, say, yes, if somebody wants to use my EKG for research purposes, sign, done. Get rid of this whole bureaucracy of trying to figure out how to, protect, I don't know if there's any thoughts on that.
I mean, that's a utopian vision, and I think it would be great if we could actually get there. But I do believe that, digital health literacy is really low, and people don't understand across large swaths of populations. What does it mean to give this data away? Right?
Yeah. And something that at our institution we've been focused on for a long time, since making some of the original perhaps missteps in that space, and an important one at our institutional level for us to continue to always think about. And it goes back to very different verticals of the economy of the global development between healthcare, ultra conservative and appropriately so. Of the concept of being informed as a patient with knowledge mismatch is hard. And we've touched on already a couple barriers that border on threats, and we're going to go into that space, and then we're going to turn to Sri and her expertise in an area of emphasis of the panel on equity. Before we get there, Ritu, we're going to pick up on what you and Rama have talked about around privacy. When we talk about digital health, there's 2 big buckets that I hear commonly. Won't digital health make it easier to have privacy violations? Is there a threat to data privacy? And where's the evidence? Does it make a difference? And so, Rama, you touched on a lot of data privacy points. I'll turn to you first on the is data privacy a threat to digital health development around the world? And then bring it back to the in-person panel on what do we say about lack of evidence in digital health?
I think the way I will argue is that I work on face recognition. I built a face recognition system. Now we had to go through some really very strict protocols whose faces we can use in training our system. I couldn't just take anybody's face in the panel today. We're all US citizens. So when we did this work for IARPA, very clearly, we had to go and get pictures of sports athletes, politicians, I mean, who are already in public domain, so much actors. I've never seen so many pictures of Bollywood actors in my life. When we were training our face recognition system, so that is what we had to do. But then there are a few other countries where there is no such issue. I know I don't have to name countries, but they can go on collect willy-nilly face data. And of course, machine learning, the more face data you give, the more diverse the data is, the better it is. So there is a company called Clearview, has 2 billion faces that they took from the website. They didn't ask anybody's permission. So they are now in somewhat deep doo-doo because ACLU is suing them. And the GDRR people say it cannot be used there and so forth, but US government entities are using them because they say it works so well. Yeah, they did whatever they did, we don't care, or something like that. Anyway, so data privacy has implications because if somebody don't have privacy issues, then they can build a better data-driven AI than places where strict privacy rules are there. I fully support whatever privacy that we need to ensure for patient. I'm not arguing that let's relax it, but let's find a way, as Shri says, to make this diverse data available for machine learning folks like me to work on, and that is very important.
Kunal, you live in the space of thinking about a specific clinical area and developing, in a really important area of medical care. What do you say to, but there's no evidence yet. It doesn't make a difference, and we live in evidence-based medicine. How do you kind of think about that in your development pathway, or what are the responses to the questions around the topic of proof?
So a couple of thoughts there. So much of my work focuses on ophthalmology.
Yeah.
And I think ophthalmology is one of the first areas in healthcare that really adapted to artificial intelligence and using machine learning and deep learning. And what I found there is that I think people went into it naively from understanding where it could be useful in the first place. And so I think that people said first, okay, well, we can diagnose these sorts of posterior segment disorders, retinal disorders. That's kind of where people started because there are these existing databases of posterior segment back of the eye disorders and the retina and the fundus. And what they found was that they have great artificial intelligence. We can diagnose disorders. We can classify different stages of disease. We can even think about progression, who's going to progress in a certain way. But the places that they were implementing these things are not where that was needed. And so many places where the data is, where there's expertise, where there's training. For example, the Arvin Eye Care System is one of our partners. We work with trauma there closely. They work with Google to develop some of the first sort of back of the eye algorithms to study sort of back of the eye disease and diagnose it. But Arvin is not a place where that's needed actually in the first place. So there is evidence of that it works, but it's not actually useful in that use case because there are people there who are already trained. There's plenty of sort of actual ophthalmologists who can do it. And so to me, it's there is evidence about these things, but is there evidence of them actually being used in the cases where they're needed the most? And so from my perspective, where that's needed the most is in diabetic clinics, it's in sort of rural hospitals, primary care. And I think those are places where no one has actually done that yet, and there really isn't evidence.
Okay, we're gonna do, I think, an intermission briefly, and welcome Ganesh. So Melody, you briefly want to initially introduce our last panelist.
Yes, thank you for joining us. We know it was a bit of a challenging moment to get here, and we have certainly all been trying to get from DC to Baltimore at some point, so understand the complexity of that. Professor Ganesh Ramakrishnan, who is the Institute Chair, Professor, Department of Computer Science and Engineering, Professor in Charge, Koita Centre for Digital Health from the India Institute of Bombay. So thank you so much for joining us. Appreciate it. Thanks. Yes.
Great. We're gonna Ganesh, you're gonna get my second question. So I'm gonna prep you a little bit, which is gonna be about implementation science and building for the end user, but that we can build for the high-end user, or we can build with equity in mind. While we get there, we're gonna start with Sri and just expand a little bit around the evolving equitech philosophy and what you're working on here in your center.
Yeah, so equitech is not a new term. Equitech it's a philosophy that goes as follows. So when we're thinking about innovation in, say, the digital health space, equitech means we are interested in promoting and nurturing diverse innovators. So on the side of who's actually coming up with ideas, we want diverse teams. We certainly believe that having diverse teams leads to more innovative and better solutions. And then on the other end, the actual solutions being produced by these innovators should be equitable and accessible to all. So we have a new center we launched this past year called Neurotech Harbor. It's essentially a virtual accelerator. It's funded by the NIH. And what we do is we're implementing the equitech philosophy in the space of technologies that address disorders of the nervous system. And in that, along the way, from calling for proposals and reaching out, we're really thinking very deeply of how do we reach diverse groups? And if they're not already diverse, how can we leverage our networks to complement teams so that they become more diverse? When we evaluate proposals, we want to, for example, this is a criteria, it's typically not on any particular sort of National Science Foundation or NIH when it comes to tell me about your great idea, which is, have you talked to the state? Have you spoken to the stakeholders? Is this going to reach the rural areas and the underserved community? Are any of those people on your advisory board? Have you talked to patients and their caregivers? You know, these are criteria that we want these innovators to already say, yeah, we've done it. And here's how we adjusted our solution and done the universal design. All the way to who we nurture and so forth, bringing in mentors into the process. We want our mentors to be diverse. We want the evaluators to be diverse. And of course, we're looking for solutions that make it all the way to that last mile. So that's what we're trying to do. I think more and more of these sort of med tech, digital health accelerators and companies are adopting that philosophy, but we still have a ways to go. Just even thinking about VC dollars, investor dollars that go to diverse teams or even, you know, leaders that are from underrepresented groups or even women in this space, it's tiny. It's embarrassingly low as a percentage in the United States at least.
Can I make a very quick observation? So you're spot on, Sri, and my center, the Center for Digital Health and AI, is part of an NIH consortium called AIM Ahead, which is Artificial Intelligence in Medicine, Advancing Health Equity and Research and Diversity. And what we're trying to accomplish is to build out the capacity amongst a diverse workforce to be able to work with these tools so they understand the specific issues and barriers that populations face. And they can bring those data and that community engagement back into the AI and solutions for health. So, you know, this is absolutely so grateful.
A question to you, Ganesh, is going to build on this. What we just heard from Sri and Ritu are some of the upfront strategies at the point of innovation to ensure equitable product development and ultimately adoption is front and center. As we think about products, we all want products to be used, and simple end user products often make that easier. But what are the strategies in product development that build on what Sri and Ritu said around stakeholder engagement to drive product adoption across patient populations and communities, especially those facing inequities? And from my side as a physician, and we already brought this up, products in healthcare often have two major customer sets, both provider and patient. And we actually already touched on equity is not just a patient terminology, it's also a provider terminology, different resources, different digital literacy levels across both groups. Just talk about some of the potential product strategies a little bit deeper on equity and deployment.
Thanks. I'll try to answer this maybe at 3 levels. The first level is wearing a purely industrial hat. I've seen the rollout of national digital health missions such as the IIT-B digital mission in India. They face challenges in terms of getting research complement the product development with. Right? So the IIT-B digital mission has a list of these digital public goods, which is a call to industry to make available their products that can be used through APIs and possibly through customization at scale. Now, that's exactly where they need research, academia to step in, both to pilot some of these projects, help build these projects in an agile manner. From my own experience in terms of products for equity, we worked a lot with the Indian farmers and being able to help them do direct marketing of their products. Now, when we build these products in an academic or industrial setting and then try and get them to the last mile, right? Get them to the bottom of the pyramid, as they say. The challenge is there's a big impedance mismatch. So being able to work in an agile manner is very important, and I think academia plays a very important role. Thankfully, at least at the level of the National Digital Health Mission, this provision has been made. For example, IIT Bombay, we are part of this BAMNI, which is an open source EMR EHR system, which is really meant to democratize the use and deployment of health information management systems for low resource, low bed hospitals in India. And the challenge they face is that while this open source, they need to make sure that there are good solution partners. Again, academia can play a very important role in hand-holding, in ensuring that there's training available. So the excitement around the industry to build solution providers and the assurance that there will be a market when they build a solution company is there in place by design, not in retrospect. So that's my point number one. The second aspect is that this AI is going to be ubiquitous everywhere. I mean, that was a reference to face recognition earlier on. Now, again, my experience back from India is the Ayushman Bharat Digital Mission has actually taken a good step by ensuring that this actual custodian of the data is the end user, which is very good, right? So that's good. So my face belongs to me. But on the other hand, if you don't provide a mechanism by which this data can be shared and models be built, my data is of limited use to myself or anyone else for that matter. Thankfully, there's this booming area called federated learning, split learning. These are buzzwords around this, where you don't have to really share the data. You can actually share parameters, meta information about the model. You could have hierarchy, you could have clusters where each cluster sends out its parameters to its parent and so on. And you can also have serverless architectures that is totally peer-to-peer structure where you just have the clients actually sharing with each other, communicating with each other. I think this area needs a lot of investigation. Thankfully, to complement our Center for Digital Health at IIT Bombay, we also have a trust lab that has been set up to really have trustworthy models of data sharing and model learning. As a classic example of this, we have a national disease modeling consortium set up at our center. And this is national in the true sense because it's got the endorsement of the National Health Secretary and Indian Council for Medical Research. Is the Director General is a part of the Advisory Council. So now with this, we have access to all the data that can potentially source on disease modeling through the length and breadth of the country. But the challenge is how do you make sure that the models you learn for tuberculosis in one state respect the privacy while being shared, while being cross-pollinated to bootstrap and improve the model in another state. So this is a very good use case, and I actually would like to invite collaborators across the world to actually step in and see if we can make this a very successful model where the custodian of the data is still the end user. But yet we at a national level we are able to do effective modeling by protecting the privacy. A third aspect to this is you get even more core ML. Now when you say equity, there's equity from a consumer perspective. Right? That's what we talked about. But there's also an equity required from a producer perspective. How do you make machine learning? How do you create a level playing field, democratize the field of machine learning per se, right? Now, do you really need lots of data? ChatGPT possibly can be a suffocator for many of us. It's not just about lots of data, but it's also large models. During my computer science hat for a while, yeah, we built out this open source platform called DECIDE, Data Efficient Learning. We're very happy there will be more people adapting it, creating variants of it. Our goal there is how do you make machine learning data efficient and compute efficient? If how can we translate the experience that a radiologist carries while annotating, while classifying images, or the histopathological slides, right, based on certain stains when they are classified. The perspective that is underlies the annotation process, can that be translated into rules or programs? This typically happens when annotations are done, there are annotation guidelines. But how do you make it a replicable process that the data generation doesn't have to be overhauled the moment that annotation guidelines change? Right? So streamlining the data annotation process and actually using the human labeler not just as crowd. I actually have a problem with this word crowdsourcing. I don't think we can use crowdsourcing in this area of digital health. What we could do is treat the domain expert as a collaborator with the machine learning model. In fact, have the capability in the model that the machine output is superseded, overridden, can be overridden by the domain expert. That the domain expert is no longer a crowd there, right? It can override. We actually build models, and there's thankfully there are startups from Stanford, there's a startup called Snorkel, which has been trying to do this. Likewise, for there's data efficiency, there's also compute efficiency. How do you make it possible to learn on edge devices? Maybe fine-tune model on edge devices. So I think this needs a lot of attention. While we have done some work, we would like more contributors to push the frontiers.
A lot to unpack there. I do think a point that both you and Sri made, and it's an important one, is when we hear the word equity in healthcare, we often do focus on consumer patient equity, but we're also hearing that that's the output. The input also should be equally broad from an equity standpoint, and unless we both address both ends, we're probably not going to be fully successful. I want to talk about models you built on some different partnership models that have driven towards some of those equity goals and digital health disruption. I want to open it up around kind of three buckets: private development, public-private partnership, and then honestly, what I would kind of say fully public or partnership as a public utility. Open ideally to all. What are the various pros and cons of those different models? And Kunal, we'll start with you first as both an entrepreneur and an engineer and an innovator and someone that's done work as well in India. Comments on public-private partnership and the ability to drive innovation, or the alternatives?
A very difficult question, as all of your questions have been today. Maybe I'll just give a little bit of background. So much of our work is in ophthalmology, so we're developing algorithm software tools for detection of front of the eye diseases, cataracts, infectious keratitis, even being able to do things like myopia and figure out what's the best treatment for certain patients. And so a lot of our work, we've never been able to get access to data sets from anyone else. And so usually that's where you see these sort of partnerships. It's one person has the data, one person has the technology to develop something from there. We've never had a case where we've been able to, there's an existing data set that someone can give us, and we're able to have access to actually develop something with that we can then bring to market. And so for us, a lot of our partnerships have turned into, we'll create the data together. And so we may have unique hardware, unique ways of actually getting that data or very specific data that's useful for this application. And we've been thinking a lot about what is the right way to actually not just develop it, but then actually deploy it at the end of the day, and deploy in a way that's sustainable, where there is some level of income that can provide support for further development, customer service, those sorts of things. And more so, I'm getting to the point where I'm getting to the public utility piece of things. And so we're about to create a nonprofit that's going to work with several different eye care systems in India, work closely with them, where they're able to work with us to develop data, create databases, and I think we'll create some of the largest databases in the world that don't exist right now. But then we'll work together with them to make sure that we actually develop solutions that can be implemented very thoughtfully and enable access to them thoughtfully, broadly, without there being a significant profit motivator that overrides all of that. And so that's sort of the direction that we're starting to go in, and to me that makes the most sense. The only thing I'll add is, I was thinking on the way here, people talk about the Microsoft bundle. you've got sort of Word, you've got all these sort of, Teams, all these sort of different things. And many people think that that's actually anti-competitive. But in my mind, I think there's actually a need for something like that. There needs to be that kind of AI sort of bundle that's done as a public utility in my perspective. And when I think about eye care systems, there's going to be software for macular eye disease, for myopia, for anterior segment, there's going to be an infinite number of things. And if there's a different, for-profit company with, return on investment to their shareholders, that's the number one thing for each of them, that's selling each of those things individually, I don't think we ever get to a place where any eye care system that is charitable or focused on impact is going to be able to actually make the best use of those, deploy those in a way that makes sense.
Me too. Thoughts on this topic?
Well, I'll just make a few observations about private investment. And there's a lot of research showing that private investment in healthcare is not necessarily aligned with the interests of societal welfare. I mean, this is a societal sector and it does need engagement of the public. So venture capital is great for initially providing the funding, but at the end of the day, we have to have the public involved in the conversation around all digital health innovations, whether it's providing the data, whether it's providing the usability, whether it's providing the acceptance. So I'm not a believer, despite being a business school professor, I'm not a believer in just private investment.
Yeah, absolutely.
So I thought it's not directly related to your question, but as my thought came. So academia does house innovators, right? They're not the only people that innovate, right? But I do think there are not proper incentives in place to promote faculty, for example, from innovating and translating. For example, how we are evaluated when it comes to promotion and tenure. Nobody cares how much data you share. Nobody looks into how much you've translated, even though it can take enormous amount of effort and time. They look at the traditional, how much money have you raised, how many papers have you published, and where, and that's impact. And I think that there's a huge opportunity to figure out how to incentivize a whole body of innovators that currently are disincentivized to pursue these types of ideas. And I know that's not directly related to your question, but I was just thinking
Spot on.
May I add a comment?
Absolutely. Yes,
May I?
please.
Yeah. So Sri makes a good point, but Sri, if you look at ImageNet, it was collected by Fei Li when she was an assistant professor at Princeton. Almost everybody told her that's not a good way to earn tenure at Princeton. And ImageNet allowed us to make this big data-driven computer vision, become things. So I think you need some people like that who, as I like to say, young people who don't listen to the elders are the ones who usually do well. And I tell my student, don't listen to what I say, do what you want to do and I'll figure it out. Anyway, so I think that's a great example. And I think she became an NAE member at a very young age. And almost all of us associate the deep learning thing to the fact that they were able to annotate 1.2 million, pieces of images with object locations and class labels and so forth. So I think similar things like that should be encouraged. It's clear now we do live in whoever has data has the power these days. So I think we should figure out a way to reward people who are willing to do these non-traditional things.
I'm just briefly, and then we're gonna actually move on to kind of the future of the digital health landscape in India, and hear some perspectives. But Sri, we made the point, venture capital may be good or bad, who knows, we could have a debate on that. But if only those in academia who are extraordinarily willing to take on career risk are the ones that can move forward in that space, then innovation will be where risk tolerance is different outside of academia. I think the point is brilliantly made. I think it's important. Let's open question to the panel. We can start wherever we want. Next, I get asked for a 5-year strategic plan a lot. I'm like, I don't know what's gonna happen in 90 days in digital health, so we'll take that for granted. Next 5 years, digital health landscape in India. Let's talk about what does that look like? Where are the major areas of change across the entire healthcare system. Big question. What's the evolution look like? Maybe Ganesh, if you want to start, and then think about it. Yeah.
Sure. So I think one big need that warrants attention and possibly will get it due in the next 2 to 3 years, if not 5 years, is streamlining the process of digital health data collection itself. And I don't really mean just building software infrastructure to do that. The backend machine learning process that's going to govern the usability of this data is as important. I gave an example of federated learning earlier, and I'll refer back to that. More the field evolves there, the more there'll be clarity on what are the access control that needs to be even sought when the data is being curated. Along with that, there's also the need for making open source electronic health record systems very robust. When I say robust, again, making conversational interfaces possible, because I realized that two things that will make the adaptation of information management systems in low-bed hospitals is one is audio input, and the other is the ability to capture not just optical character recognition, but also digital pens in input, but low resource. So which also means you need to come up with better devices for input. So these are two areas: the processes underlying the data consumption from a machine learning perspective, and the input modality, making it multimodal for health information management systems. I think this would need a lot of attention in the next few years from the researcher perspective, from the insurance sector perspective. The second area, which probably needs a lot more health economics and policy thought, is what would be the right incentives to make that happen. You've seen with our example with the adaptation of unified payment interfaces in India. In case you've heard of the Aadhaar ID, right? It just is so ubiquitous. I mean, the people, the fruit vendors would have this UPI app to make payments possible. So that's great. Now that became possible because of a lot of incentives associated. Some arm twisting as well at times. Now that is another area that needs a lot of attention. What would make the equivalent of this Aadhaar ID? We have something called the Aadhaar ID, health ID. How do you make sure that everyone has a health ID and ensure that the hospitals make use of the health IDs to create handshake across health records which sit in different hospitals? There's no handshake currently. So that would need a lot more thought beyond just the next 2-3 years. So I would say that would probably span the next 5 years. And going forward, beyond these two, what is exactly a patient or the end user going to see in terms of the life cycle of such data? Is it just about better insurance turnaround times? Are there other metrics that we could associate with the satisfaction of the patient or the end user? I think this will need probably thought beyond 5 years, but I think that will again span the entire 5 years that we talked about.
Any other comments on what else might be in scope over the next few years in the Indian context?
So there's been an increase in the number of NGOs focused on digital health. So an example is GKII in Rajasthan, which is actually out of a Indian classroom project that has really evolved. I see a lot of growth in that space. I've also been doing some work on these digital health platforms in India that are helping to inform consumers, patients about what options are available. So, similar to what we have in the United States, appointment booking and taking some of the frictions out of getting access to medical services. So I think that's going to be another space for growth.
Maybe I can just add,
Absolutely.
not what I don't know if this will happen, but it's a hope that will happen. When we first started working in India, partnering with different eye care systems, the feedback that we got was in the US was, wow, these are the best eye care systems in the world. They're just as good as anywhere in the West. They have the largest number of patients that they see. AIMS, ARVID, these sorts of groups. When we started speaking with NGOs, they said, well, you're just speaking with the best of the best. They don't really need much help, right? And so as we've gone now and sort of further develop partnerships, reach out to other eye care systems, there are many that don't have basic EHRs, they don't have basic equipment to actually do diagnosis, do treatment. These are actually the places where I feel like the need is the greatest. There are, we need AI that can help because you don't have enough trained personnel, to help with these sorts of things. And so the hope for me is that we get those eye care systems, those sort of care system providers to the place where they can actually benefit from these tools that will be there within 5 years. And to me, that's kind of the thing that floats the boat the most.
If I can make a very quick comment, I think let's assume 5 years or next few years, we have AI working in a physician's room. Should there be a sign saying that the doctor is also using AI so the patient knows that? Because we are now looking at the triplet, AI, human, the physician and the patient. We all trust our doctors and we do what they say we should do, based on whatever recordings that have been done. But if the doctor says, I'm also looking this deep learning machine, which tells me that you should go for this and this and that, and the patient says, hey, I don't know anything about deep learning. Did it go to Harvard or Johns Hopkins for education? So why should I believe that? So that's going to be becoming important. So at what time we have to put a note saying, just like video camera is looking at you, you have to do it to let people know the camera is taking the picture. AI is at work here, and what's going to be the situation and when you're going to declare it, or we're going to assume that it's all going to be okay because the patient may have a right to know. That's why all the doctors put their certificates in the room, right? They went to they got the MD here, they got the fellowship here, and so on. So you look at it and say, okay, the doctor has gone to good places, so I trust what he or she is doing to me. So it's going to be an interesting development how the triplet dynamics will develop and gain trustworthiness all around. So with that comment, I have just a few more minutes to listen, and then I have to run to another meeting. Thank you so much for having me on the panel.
Thanks, Rama. And with that prompting, with a few minutes left, I don't want to miss this last question, which all of us affiliated with or partake in academia, and part of that role is to, in my opinion, is to inspire. And so for those young researchers, engineers, students, clinicians, what's one piece of advice that you all would each pass on to them if they're interested in this broad space of digital health and technology and healthcare delivery? We're gonna go down the line and start with Sri.
Yeah, so I would advise any student, and I implement this advice with my own students, PhD students, is if you're going to be in digital health and you have the mastery of AI, if you're the engineer, don't just try to say, I've got a set of tools, give me data, I'm gonna create a great solution. You need to immerse and become a domain expert in the application. So I encourage you, go to the clinicians, watch what they do on a day-to-day basis. Get yourself a desk at this hospital site and you learn that space. So all my students sit in the epilepsy monitoring units with my clinical collaborator, and we co-mentor. So I think you've got to actually become an expert as much as you can in the clinical domain as well.
That's fantastic. As a clinician, I completely agree with that.
Yeah, become a very good listener. I don't think that, to the previous point, I don't think anyone grows up thinking I want to have tenure. Right? But I do feel like what's important to think about is what is the greatest good that you can imagine doing in your lifetime, right? And I think that as it relates to digital health, things that we're doing here, seeing the impact of it, you can have an impact on innovative business models for deploying these things, developing new technologies, thinking about how to implement them the right way, how to make sure we're applying them to the right use case. But I think fundamentally is where do you feel like you can have the greatest good, and designing your career and your experiences to enable it to do that.
So I'm just going to riff off what Kunal said. If you want to wake up every morning and feel excited about what you're doing and feel like you're having an impact not just on the narrow set of 6 people who will read your paper, but also on a population in the United States and all across the world. I do think the digital health transformation is at the inflection point, and it's time for everybody to go through it.
So, building upon what she suggested, it is in the Indian context. I would certainly advise the students to sit with clinicians, AI aspirants to try and understand what is the initial task in terms of recording observations and up to the point of analysis and prescription. But I would actually go a step further, at least in the Indian context again, to the large 90% of the population which has very less access to clinicians. How do they even resort to solutions? Who are the quacks around who possibly proxy for these clinicians? I mean, with respect, I don't need to demean the quacks, they play an important role. Yet, what are the places where they could leapfrog and ensure that the already hard pressed for time clinicians, their efficiency can be improved? What aspects of telemedicine really need focus? If to address this skewed doctor-patient ratio that we have in India. So I would advise them to sit at AIMS, but also go to a remote village in Bihar where they don't have access to any of these advices that we talk about.
Rama, briefly, if we have you first.
Well, I try not to advise young people, they don't listen. Just kidding. I just tell them to be passionate in whatever they do, not to worry about getting a job in Amazon or one of those FANG companies, but do what interests them, and eventually everything works out. So, but being passionate about what they do is what's important. That's what I tell them. And I tell them not to listen to me.
We have your answer to this, given your pathway, your journey.
Yeah. I think passion and impact are the two key points that stood out. As many on the panel know, I had a winding road to find my way to this mixed role in healthcare delivery. And it's because I didn't really know how I could deploy myself. And it took a long time to figure that out. And so I think my main message is don't be afraid to get it wrong first. I mean, the concept that you can know exactly what your life career looks like at 8, 16, 18, or 21, or 25, or 30, to me is a misconception. So fail fast in career development as well. I think it's critical. Melody, I think we'll turn over. I think we did well.
You did amazing. I cannot believe the vast amount of territory that we were able to cover in such a short time. So thank you so much. It was, really interesting and a beautiful setup to what I'm so thrilled to be able to announce is that through a collaboration with the India Institute of Technology in Bombay, we are able to now begin a seed grant program co-funded by both of our institutions, where every year we will have 3 research projects that will be funded for interdisciplinary collaboration between the 2 schools to solve a health challenge. Many of the challenges perhaps that you have laid out, we can begin chipping away at. So this is a wonderful moment for us to be able to make that. And thank you all for this really stimulating conversation. I would like to turn it over to Hetty from the Whiting School of Engineering to wrap it out.
It is truly a pleasure.
Oh, we have the formal document.
Oh, you
Formal
do.
signing.
So
Very
that is-
exciting. Terrific. Well,
Suri is going to sign it, but before doing that, we would like to also welcome Professor Nitish Baker, who's joined us. Any words?
However, no, I'm interrupting some grand ceremony here, so I'm coming here as a friend to all the places.
Thank you so much. Also a
so
graduate
why
of
don't the 2 of you
IIT
slide
Bombay.
together and sign this important MOU?
And they have already signed by
Okay.
actually, Suri is going to
I'm just
represent
saying
it.
on behalf of it. I look nothing like it, but I'll do my best, okay.
So. There's a document, collaboration agreement between Johns Hopkins University and the Indian Institute of Technology Bombay on this breakthrough grants.
And then we have a collaboration agreement between Johns Hopkins University and IIT Bombay. We're in collaborations between the schools for student exchanges and with undergrad, grad level research opportunities and so forth. So we're really excited.